This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care, or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello, friends. Thank you for the download. Today's Senior Rehab Short is a very special episode because it is the recording from the monthly meetup of September with the Game Changers. The Game Changers are motivated clinicians and one patient, Lisa Maxura, who are paid members. So they are in their own private Facebook group. We have a monthly meetup where we discuss a pertinent or relevant article, a peer-reviewed article that we try and pull out the practical applications for our work, so we can actually change as a result of reading some of these dense journal articles. I also look to them for direction of the podcast. Aaron and Tally do as well. We ask them, what do you want to hear? Who do you want to have on the show? And really just seek their feedback for the direction of the podcast. So it's definitely kind of the inner circle of the Senior Rehab Project, and some very prominent figures in our PT world, if at least in my eyes, and some people that I just really, really respect that have a big, big heart for advancing care for older adults. So if you're interested in joining this group, go to seniorrehabproject.com/game changers. Link will be in the show notes as well. But this month we talked about slow processing speed predicts falls in older adults with a falls history, a 1-year prospective cohort study. So this was in the Journal of the American Geriatric Society, released in 2017. I'm going to just go ahead and read the abstract. I'll put a link in the show notes as well. So the background/objectives. A previous fall is a strong predictor of future falls. Recent epidemiological data suggests that deficits in processing speed predict future injurious falls. Our primary objective was to determine a parsimonious predictive model, I'm special people, of future falls among older adults who experienced over one fall in the past 12 months based on the following categories: counts of total falls, indoor falls, outdoor falls, or non-injurious falls, and one mild or severe injury fall, and an injurious instead of a non-injurious fall, and an outdoor instead of an indoor fall. Much easier to read than to listen to, people. So you'll want to click on the link in the show notes. The design, it was a 12-month prospective cohort study. The setting was Vancouver Falls Prevention Clinic in Kenyatta. Participants, 288 community-dwelling older adults aged over 70 years with a history of over one fall, resulting in medical attention in the previous 12 months. The measurements, we employed principal component analysis to reduce the baseline predictor variables to a smaller set of 5 factors: processing speed, working memory, emotional functioning, physical functioning, and body composition/fall risk profile. Second, we used the extracted 5 factors as predictors in regression models predicting the incidence of falls over a 12-month prospective observation period. We conducted regression analyses for the 7 falls-related categories. Then the results. Among older adults with a falls history, processing speed was the most consistent predictor of future falls. Poor processing speed predicted a greater number of total, indoor, outdoor, and non-injurious falls, and a greater likelihood of experiencing at least one mild or severe injurious fall. The conclusion: poor performance on the processing speed factor, a trainable factor, was independently associated with the most costly type of falls, injurious falls. There you have it. Much easier to read than to listen to, like I said before. Click on the link in the show notes and enjoy our conversation of kind of the practical takeaways that we drew from going through this article. recording. So I'll probably just read the abstract and give kind of an introduction. All right, so we're talking slow processing speed predicts falls in older adults with a falls history, a 1-year prospective cohort study published in the journal, the American Geriatric Society. Okay, this is a dense one statistically. Aaron, you want to speak to that? Introduce yourself. Give us kind of a quick who you are, what you do, where you are kind of deal.
Sure.
And then your thoughts on just kind of the stats versus the clinical understanding of everything.
Yeah. I'm Erin Carey. I'm an associate producer at Senior Rehab Podcast.
Woo-woo.
I'm also a recent graduate of New York University's DPT program. So I'm employed right now. Studying sports.
That's great.
Thanks. But anyway, so when I was reading through this article, I found it very easy to get lost in the statistical density of it. Like, I did a lot of Googling, and it's still I still am very unclear on many aspects of the statistical analysis. So I feel like a clinician practicing and wanting to learn about slow processing speed would see the first couple lines of the methods and be like, and on to the results, and kind of miss out on that component, which may or may not be really important.
Yeah. I'm one of those clinicians, I will confess. Okay, so let's kind of get into just, I guess, some of the critiques that we had, or just thoughts about the article. Jamie, could you mention just about one of the measures that they had, the reporting of falls?
Sure. Well, my intro. This is Jamie Louie, home health physical therapist. Dustin likes to use the word extraordinaire, but I just say I treat people in the home in California.
Yeah.
So one of the interesting measures, and with this particular study, is that we're looking at these community folks and the population that was most likely to have a fall based on self-reporting of falls were those who were mildly cognitively impaired. And so the big question is, how accurate is that reporting? Are they overestimating? Are they underestimating? Are they even understanding the definitions of what fall is? I know they've got some exclusions for things, but again, when we're looking at this particular type of study that's uncontrolled in terms of the population, because they're not in a skilled environment, I think we have to maybe question a little bit how the data was collected and how accurate it was compared to if these were all falls that were observed in a skilled environment.
Yeah.
Yeah, and I can jump in there. I'm Jessica Roberts. I'm a physical therapist, and I own a mobile practice heavy on the health promotion and prevention side of things. But to Jamie's point, to us, it does seem like a weakness, and that is understandable, definitely. In the article, however, they mention that falls calendars, so this self-reporting on a calendar, recalling it after the event happens, is actually the gold standard measure. But we were wondering if an opportunity for future research might be to include different accelerometer type devices, velocity sensors, where the participant would wear something on their person, and that would kind of monitor these adverse events versus their subjective recall, and how that could be especially helpful with different cognitive impairments.
Yeah, and I didn't realize, and Jessica and Nicole, I believe, brought it to my attention, that Lifeline, I don't know if that's the exact brand, but they're already doing that. Just have an accelerometer, and that will trigger a call to EMS. So that's pretty cool. But I think one thing, Nicole brought this up, what is a fall? Just kind of that.
Yeah.
All right, so my name is Nicole. I'm a physical therapist in a SNF setting at the Jersey Shore. So I am in a building surrounded by people who are generally there because something bad has happened at home or they've been hospitalized. So I'm seeing them way after the fact. So according to this study, falls are defined as unintentionally coming to the ground or some lower level and other than as a consequence of sustaining a violent blow, loss of consciousness, sudden onset of paralysis, as in a stroke or epileptic seizure. So this is a pretty specific definition of a fall, and I can tell you that I have had plenty of patients who will tell me they didn't have a fall. They sat down quickly, or they caught themselves on the wall, or they slid down to the ground in a controlled way because they don't want to admit to falls. And these are people who were like, you went to the hospital because you fell. And they're like, it wasn't really a fall. Mm-hmm. I'll have patients who fall in the building, like while they're there. And they'll be like, I didn't fall. I just lowered myself to the ground because I was trying to get my shoe. And you're like, that is still a fall. So, I mean, if I'm seeing this level of manipulation of what a fall is in a controlled environment, I can't imagine that people were 100% accurate in their fall reporting, because, you know, people don't want to tell you they fell, especially if they feel like they're going to lose their independence.
Mm-hmm. Yeah. So those were kind of some of the things that we were thinking about in terms of the critique. So the results showed that slow processing speed is a huge predictor of falls in older adults. So the first question that, you know, basically came to all of our minds is, all right, what do we do with that? Do we screen? Do we refer? So yeah, what are your all's thoughts? Let's start, Nicole, if you could just kind of give us your perspective, and Jessica after that.
Yeah, like I said, I think I have a little bit of a cheat here because of the building that I'm in. We have a really good relationship across disciplines. So I can trigger a speech eval, or at least a speech screen, very easily. All I have to say is generally, hey, I was in this eval with so-and-so, and they seemed like they were kind of off. Either they were slow to follow directions, or they were having problems motor planning, or they just seemed confused. Can you take a look at them for me? Mm-hmm. So cognitively, I have a little bit of wiggle room. I can get someone else in there fairly quickly and fairly easily.
Yeah.
And I was wondering, and this is something I thought, like, would it be enough to, or would it be worth it to say, you know, in my department, maybe falls should just trigger a speech eval, you know, because generally speech doesn't come in for a fall unless it's something that we asked. But maybe they should just be coming in there and doing, you know, a quick screen for processing speed on people who have had falls. That's why they're there.
Yeah. About you, Jessica?
So on the opposite end of the spectrum, being a private practice owner and a solo practitioner, understanding that cognition is a huge part of the picture of falls, we discussed like a potential screen to ensure that we are looking at all the components would be the mini cog, which is a really quick screen, and it can give us a picture of recall and some spatial perception issues and a lot of other things following commands and whatnot, and can give us an idea of if there is any mild cognitive impairment, and maybe that means referring then to another provider to address it further, as well as that should inform our interventions as well as we get a better picture of what's going on.
Yeah. And Shweta is with us as well. She did the CEEAA course. Did I get that right?
Mm-hmm. Yep.
I always butcher it. Yeah, tell us what you learned there in terms of cognitive screening.
Hi, I'm Shweta. I'm a physical therapist practicing in a SNF in Utah. And when I took the CEAA course, I was told that we as physical therapists also play an important part as far as cognitive screening is concerned. So there are a couple tests like the mini-cog, MOCA, the trail-making test, the mini-mental status examination that we can use. And I think a mini-cog is a really quick screen that we can use on our patients while we are doing our eval. So because it doesn't take too much time, and it's just like 3 questions, and if we feel that there's something different that we found in the patient, we can always refer them to speech or occupational therapy, so they can do a thorough eval and figure out what level they're at.
Awesome. Okay, so that's what we do with that. We could refer, we could screen ourselves, and then the other question that this article, answers is saying, can we actually impact this? And they say, we can. So Jamie, what are your thoughts on that?
Well, again, it's an interesting summary, because they did look at least at one study where processing speed was influenced by using some visual retraining. And when they looked at a particular group of test subjects, horrible thing to say about a person, but they only had 21 people in that particular study, where they were comparing that group to a group that just did some leisure activities to see if somehow there was a difference in their improvement in processing speeds. And, you challenge the system and you expect maybe there's going to be some improvement versus just taking it easy and not doing a lot of difficult tasks like the leisurely activity. I wasn't sure that really gave them the strength of that conclusion in terms to a point, I don't want to say reversible, but trainable enough that it would have an impact on reducing the risk of future falls for that particular group.
Yeah. So some of the big practical takeaways, we have the screening, we have the testing, and then, how does that influence our intervention? So good thing we have Meg Lowry, who is the physio from Down Under, who you all have heard. I think she's done a few shorts. I still need to interview her. But she wrote a book called Balance Yourself, and she has an app called Clock Yourself. I'll put a link in the show notes to all this good stuff. But this is something that she's been talking about for a while in terms of, adding that layer of a cognitive challenge to our interventions and how we can pack so much more of a punch with our treatment sessions to impact our patients. So in this book, I'm not going to give it all away, but she does a great way of laying out this framework, and this is patient focused, this book called Balance Yourself, where there's different tasks that you can alter some of the different variables to make it more difficult, whether it's base of support, hand position in terms of the upper extremity support, if your eyes are open or eyes closed, things of that nature. But then also some different things that you can do to increase the cognitive demand of that task. So whether it's just thinking about or naming, recalling something, memorizing something, or repeating a tongue twister, which she has some funny stuff in here. But it's a great resource that definitely will get you thinking about what you can do differently when you're just doing the random, standing Therex at the sink, that you could throw on another layer of, cognitive demand to really pack a punch. So just anything in particular, just quick, actionable steps that people could use tomorrow to, just actually take some of this information that we discussed and, help their patients.
I think they could use the mini cog and screen their patients if, like, during the eval they find that maybe this particular patient could be an ideal candidate for a speech or occupational therapy referral for cognitive therapy. And also when we use tests like the tug, or when we use any kind of gait tests, or when we're doing gait training and things like that with patients, we can always add cognitive tasks. I know, there is this task of backward counting by 3 or by 7, which we can add to the tug, or even while gait training, which could be more challenging for the patient.
I would say don't be afraid to distract people a little bit while they're doing something, especially if they're starting to find a task easy. Talk to them while they're doing it. Ask them questions. Throw on some background noise. Anything that might make them think a little harder, might make them work a little harder, even if they don't realize that you're doing it. Sometimes people, if you start asking them questions or have them do things, they might get a little flustered. But if you're just talking to them and engaging them, sometimes you can get some cog stuff going without even them realizing it.
I think memorizing, that was a cool thing we talked a little bit about in terms of, whether it's a joke, getting them to memorize that, or, a number of words or a short story, but, telling them that, getting them to remember, perform a task or intervention or whatnot, and then having them recall that task at the end. I mean, just something super simple. I mean, this does not take extra time. I mean, this is just in the middle of a rest period that we could do, but I often forget to do it. Anything else? Any closing remarks?
Yeah, and I just had one that just came right to my brain.
This is dangerous.
That goes back to our screening and our assessments, and that is, we need to be aware that visual processing is a big part of balance. When we screen for, say, potential vestibular issues, we are doing some visual tracking testing, as well as even having them look and identify objects in a distance, see if they've got good depth perception. And I think that's another element that we need to be aware of, is that the ability to process visual stimulation is not just macular degeneration. There's a cognitive element to it. Mm-hmm. So if they don't recognize obstacles as threats, they're going to continue, and I think it was Nicole brought up the person that kept walking into the wall. They don't recognize those things as something that could harm them. So it really is on our shoulders to help them identify those. And I think that's part of that visual processing, is how quickly do they see an object like a stair and say, oh, I have to change what I'm doing before I get there. Yeah. I think that timing becomes really important for the balance. And I think that's the element that maybe we kind of danced around a little bit, but that really is that processing speed of how quickly they recognize threat and versus something safe.
Yeah, that's such a good point. And I think that's a good place to wrap up. Just thinking kind of big picture. It's not just about their muscles, their lungs, their heart, but, we have this very complex human being with all these different processes that impact their function. And we have the skills to, at least screen, most of those systems. So, all right, well, thank you all for chatting about this. Listeners on the podcast right now, slow processing speed predicts falls in older adults with a falls history 1-year perspective cohort study. Links will be in the show notes. I'll link the mini cog, the trail making tests, and any of the screens that we mentioned before, and Meg's book and Clock Yourself app. So you all will be able to view that. Awesome. Good work. There you have it, folks. Big thank you to those that joined the monthly meetup for September. I had an awesome time, learned a lot, and definitely has me thinking differently about how to apply some of the things that we discussed. A big shout out to Meg Lowry down in Australia. Link to her app and her book will be in the show notes. She is doing some awesome work, and I definitely want to make sure that you all are well aware of what she's doing. She's also a game changer. So want to, just encourage you all to consider that. So seniorrehabproject.com/game changers. You can get in on the fun on the monthly meetup, meet monthly with some really motivated and smart clinicians to discuss pertinent evidence and articles, but also have a say in the direction of this movement and be surrounded by some pretty awesome clinicians, and Lisa Maxura as well. Lisa Mac and Cheese. So thank you all for listening. I appreciate you all, and we're going to have a fun episode on this Monday, and I'm looking forward to releasing it. We're turning 2 years old. It's crazy. 2 years already. Doesn't seem like it. But yeah, so more to come on that. Thank you all, and I appreciate you greatly. Hit me! Thank you for listening to the Senior Rehab Podcast. If you enjoy this content, I highly encourage you to go to seniorrehabproject.com, where you can find more helpful episodes, lots of free resources, and to see how you can become a game changer and influence the direction of this movement. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky. This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care, or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. This podcast is brought to you in partnership with the Geros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at geroscollective.com.